It's quite important to understand the basic pathophysiology underpinning tachyarrhythmias. Now, tachyarrhythmia is another word for tachycardia, and as we said before, tachycardia is when you have a heartbeat that is above 100 beats per minute. Now, there are three main mechanisms for tachycardia to occur. One is that you have a triggered electrical activity, so you have a focus, you have an abnormal area in the heart that generates pulse. So normally, as we said, you have electrical activity go from the SA node and then goes to the atria, and then from there it goes to the AV node. You cannot go directly from atria to ventricles. Everything has to go through the AV node, and here you get a delay for some time for the AV node and then the electrical signal is propagated throughout the bundle branches and then Purkinje fibers into the rest of the heart, right? So if you have an abnormal electrical activity, you have a focus here or multiple foci that start generating pulse as well, which eventually can get conducted into the AV node as well. So this is what we mean when we say you have a triggered electrical activity. So it could be one focus, one point that generates an abnormal activity, or you can have multiple foci. The other cause is that you have increase in automaticity, and automaticity is really the ability of specialized heart cells to generate their own rhythm. So the SA node would have automaticity because it can generate pulses, AV node as well, so they're all able to generate their own pulse. If you have anything that increases the automaticity for one reason or the other, then you have an increase in heart rate. For example, increase in sympathetic activity will also increase heart rate. And then you have the third one, which is re-entry. And by re-entry, we mean you have an abnormal connection or abnormal pathway where you have an abnormal rhythm that goes in circles. So if you have an open connection between the atria and ventricle, for example, like here, for example. So normally you have isolation, right? So nothing goes from the atria to ventricles without the AV node. Everything has to go through the AV node. But if you have, in some patients, you have an abnormal connection where you have an opening here, for example, so that the pulse can go from the atria to the ventricles through this abnormal connection. And then it goes to the ventricles and goes back through the AV node and then goes back through the abnormal connection. And then you have a re-entry because the pulse keeps re-entering this abnormal circuit that it made on its own. So these are the three mechanisms you need to understand, because all forms of tachyarrhythmias will fall under one of these. Now, generally, you need to know that all tachycardias can be paroxysmal or can be sustained, and by paroxysmal, we mean it just comes and goes. You have sudden onset and sudden offset, or sustained that's just prolonged. Okay. Generally, you can classify tachyarrhythmias into two groups. The first one is supraventricular tachyarrhythmia, and the second one is the ventricular tachycardia or tachyarrhythmia. And the main difference is anything that is above bundle branches would be considered supraventricular tachycardia. So supraventricular tachycardia include any abnormal rhythm coming from the atria, but also AV node. So this will be atria plus AV node. And you have ventricular tachycardia, which is anything below the AV node, okay? So how can you make a quick distinction between the two? Just in your differential diagnosis, when you see a patient, what should you think about to make supraventricular tachycardia more or less likely? So if you have a patient who's hemodynamically stable, it's more likely to be supraventricular tachycardia. Patients presenting with ventricular tachycardia or ventricular fibrillation, especially ventricular fibrillation, are usually hemodynamically unstable. Now, if you can terminate the tachyarrhythmia with vagal maneuvers, which we will discuss in a bit as well, then it's more likely that you have an AV node involvement. So the AV node will be involved because once you use a vagal maneuver, you delay the AV conduction of the signal. We'll discuss this a little bit more in detail in the next section. If you have a long history of palpitations, it probably means that the patient has supraventricular tachycardia. This is not set in stone, so it could be ventricular tachycardia as well. But the thing you need to realize that it's more likely or less likely. If you have narrow QRS, you will have supraventricular tachycardia, and this is because if you have supraventricular tachycardia, the conduction of the signals of the pulse will always go through the AV node. So once we have the conduction going through the AV node, the QRS will be normal, unless you have other abnormalities, which I will discuss later on. And then you have no fusion beats present. I will explain the fusion beats in a second. Now, if you have ventricular tachycardia, usually the patients are mostly hemodynamically unstable, but they can be stable. right? If you have a history of coronary artery disease, if you have a history of myocardial infarction, if you have a history of structural heart disease, then ventricular tachycardia is more likely. Syncope is common in this form of tachycardia, and you have wide QRS complex, and this is mainly because the tachycardia begins from the ventricles. You don't follow the normal route of conduction. So instead of the delay that you have and then everything contracting at the same time, you have each layer of the ventricles or the cells, the myocytes, contract separately. So you'll have, because they contract in a different pattern, they will take a longer time. So if you look at this, normally it goes through this route, right? So it takes time and then everything contracts at once, right? But if you have an abnormal rhythm, then the ventricular contraction will start here, then you have this area will contract, and then this area will contract, and then this area will contract, and then this area will contract. That's why you have the QRS complex a bit wide. So 140 milliseconds, this will be above 3.5 small boxes, so more than 3.5 small boxes. And then if you see something called fusion beats or capture beats, you should immediately think of ventricular tachycardia or ventricular abnormality. Now, what are fusion beats? Fusion beats are when you have the beat of the ventricle fusing with the beat of the atria. So normally when you have ventricular tachycardia, what happens is you get no communication between the ventricles and the atria, right? Because the ventricle is beating on its own. However, sometimes the beat coming from the atria, the beat coming from the SA node, is able to go through the AV conduction and go through the normal rhythm. And then what happens is you get the normal QRS complex fusing with the ventricular complex. And this you see here, right? So you see here, this is a ventricular beat, and here you can see an SA QRS complex that managed to go through the conduction. So if you see this, you know it's ventricular tachycardia. If you also see something called capture beat, in which you see a normal QRS complex in between all the random ventricular beats, so you see this, which is a normal QRS complex, then you think this is a capture beat. We kind of like captured a normal QRS in a way. Okay, now let's talk about the regular and narrow complex tachycardia. So if you have a regular rhythm and if we have narrow complex, that means it's less than 120 milliseconds. Okay, so if we think about our differential diagnosis, we talked about generally in the beginning, you need to think about two things. The first one is sinus tachycardia, and the second thing is supraventricular tachycardia. And the distinction is made here because the sinus tachycardia is mostly caused by secondary causes. So it's mostly something other than the heart that is causing the problem. So you need to investigate what's going on. If you have supraventricular tachycardia, then it's probably or almost definitely the heart that is the problem. And then the supraventricular tachycardia can be subdivided into atrial tachycardia, atrial flutter, AV nodal reentrant tachycardia, and AV reentrant tachycardia. Now, atrial fibrillation is normally considered part of the supraventricular tachycardia because it starts above the AV node, right? But it's not included here because here we're talking about the differential diagnosis of regular rhythm of the ECG of the heart. Okay, so if we talk about sinus tachycardia, just think about it that the heart is going crazy. The heart is going really fast, but everything else is normal. So we'll have normal morphology. So the shape and axis of the P waves will be exactly the same. Everything will be fine. The sinus P wave will be present before each QRS complex. However, because it's going very fast, you don't always have time for the T wave to go back to normal before you get the firing of the second P wave. So what happens is you get something called camel hump appearance, and I will show you here what it looks like. It looks like this, right? So you see this kind of like camel hump appearance. This will be the T wave, but it doesn't have the chance to go back all the way to where it should be, and then you get immediately the P wave starting immediately afterwards. And it's usually, as we said, it's secondary to non-cardiac causes. So let's talk about what else could it be that can cause sinus tachycardia, right? So the secondary causes of sinus tachycardia, you can think of physical, emotional stress or pain. Sometimes it's normal to have sinus tachycardia. So if you go for a run, then it's normal to feel palpitations. It's normal to have sinus tachycardia. Sometimes it's very stressed, or you're very worried, or you're very afraid, you will have tachycardia. With pain, sometimes prevalent. You also see it in patients with pulmonary embolism or hypoxia. You see it in patients with electrolyte imbalance. You see it in patients with anemia, hypovolemia, patients that use drugs, whether they're like medical drugs or recreational drugs or stimulants. Endocrine endocrine diseases can also cause sinus tachycardia, and I have drugs here twice, and psychiatric causes, something like anxiety or panic attacks or stuff like this. Okay, so what's the workup? The workup for sinus tachycardia: any patient that comes in with palpitations and you do the ECG and you see sinus tachycardia or you see normal ECG, you should always check for secondary causes because it could be the reason for it. So the workup is, if you think of endocrine causes, you need to check hyperthyroidism. So hyperthyroidism can cause sinus tachycardia, and for this you need to check the thyroid function test. However, hyperthyroidism will present with other symptoms such as heat intolerance, weight loss, tremors, and stuff like this. So this would increase the likelihood of the palpitation being caused by hyperthyroidism. You also have hypoglycemia, which can cause palpitations. Then you check for blood glucose. This is usually seen in patients that are known to be diabetic, or when you check the glucose, you will find that the patient has low blood glucose level. And you can have phemochromocytoma, which is a tumor of the adrenal glands where you get an overproduction of noradrenaline and adrenaline, and then you need to do urine metanephrine screening, which will tell you if the patient has phemochromocytoma. Now for the other causes like anemia, hypovolemia, drugs, you need to do full blood counts and maybe drug panel. Drugs that can cause palpitations, something like cocaine for example. Sometimes beta agonists will cause heart palpitations. If you stop beta blockers, sometimes they cause palpitations. Anticholinergics can cause palpitations, and stimulants as well. So for some people, drinking coffee will cause palpitations, so caffeine or alcohol as well can cause palpitations.